For many diseases, well-defined diagnostic and care pathways guide patients, doctors, and caregivers through the patient journey. That's not the case for Alzheimer's. This panel will discuss what the pathway should look like, starting from the moment a patient prepares to discuss their brain health with their doctor, through subsequent referrals to specialists and treatment options, to exploring potential involvement in clinical trials. So, what needs to happen so people with cognitive impairment have a smooth path to a reliable diagnosis, appropriate treatment, and access to clinical trials? Dr. Jeff Cummings leads us in that conversation.
Hello, everyone. Welcome to our panel on the patient pathway, beginning the journey with cognitive impairment. I'm Jeff Cummings. I'm a neurologist. I've seen a lot of patients with Alzheimer's disease in my career. I'm primarily interested in clinical trials and drug development, and I direct the Chambers-Grundy Center for Transformative Neuroscience. We have a remarkable panel for you today, and I'm going to ask each of our panelists to introduce themselves, beginning with Rebecca Chop. Dr. Chop, please.
Thank you so much. I'm Rebecca Chop, and I live with Alzheimer's. I have become an Alzheimer's activist and educator, and also an author of a book about my own experience with Alzheimer's.
Thank you. And Dr. Monica Parker, could we have your introduction?
Sure. My name is Monica Parker. By training, I'm a family physician. I now direct family physician and geriatric primary care provider. I now direct the Outreach, Recruitment, and Engagement Core for the Goizueta Alzheimer's Disease Research Center at Emory University.
Thank you very much. Great to have you. And Dr. Burns, Dr. Jeffrey Burns, could you introduce yourself?
Sure. Yeah. Thanks, Jeff. So I'm Jeff Burns. I'm a neurologist, and I co-direct the University of Kansas Alzheimer's Disease Research Center in Kansas City. And I also oversee our memory clinic, which is really one of the only memory clinics in Kansas City, but also across the state of Kansas.
Thank you, Jeff. So what we're doing on this panel is to try to understand the patient's journey, particularly from the beginning. And one of the things that we will try to achieve is a definition of best practices, so that one of the products of the summit will be a definition of best practices for engaging patients in the evaluation in this new era of Alzheimer's disease therapeutics. So we're going to start with you, Rebecca. It's remarkable that you're with us. Thank you so much for being willing to step forward and say, I have Alzheimer's disease. Not everyone is willing to do that. So we're anxious to learn from you today, and would like to start by having you describe what it was like to seek a diagnosis of Alzheimer's disease. What was your initial experience like? What made you raise this question? And then what was your encounter with the medical system?
As you know, Dr. Cummings, I was one of those rare people that didn't raise the question, didn't even think about it. I was the chancellor of the University of Denver, was having a fantastic time, went in for my annual physical, and she asked me how I was doing. I said, great. She said, has anything changed? And I said, I've started sleeping. I've never been one of those people that slept very much, and she knew that. And all of a sudden, I was sleeping 8-9 hours. She said, anything else? And I said, well, I got lost on the way to your office. Now, I didn't usually get lost, but that day I got lost, even with GPS. At the end of the exam, she asked me if I might take a mini-mental status of one of those brief cognitive exams. And I arrogantly laughed. I'd never failed an exam in my life. I failed it. She sent me on for months and months of testing. I had an MRI and a brain PET scan and a psychoneurological exam, and it took months. And then I went to a neurologist, and my neurologist was having a bad day. I think she was just having a bad day. And she said, you have Alzheimer's. Now, I knew that could be the diagnosis by now. I was devastated. My husband pulled himself together to say, What can we expect? And that neurologist said, probably in 3 years, you won't be buttoning your shirt. I sought another neurologist. This one said the exact same thing in terms of the diagnosis. You have Alzheimer's. And then she said, but there's so much you can do. Now, this was 6 years ago. It was before any of the treatments were in the field. But she told me about lifestyle. She told me about diet, exercise, creativity. She told me to live with joy. And she told me I might be fine for 5 years, 6 years, 7 years. She told me soon there would be medications. And they were experiencing some people, even without the medications, to live many, many years. Now, what the point I want to make is, other than that one neurologist who I like to think was having a bad day, my story is best practice. A primary care physician caught it before I even could, and a neurologist encouraged me to live well. But now, as an educator and activist, I've talked to so many people who don't have my story, people who beg to be tested. My sister begs to be tested. My mother and grandmothers both had Alzheimer's. Her doctor still won't test her. Or others who get tested and the doctor decides not to tell them. My story is best practice, but we need more best practices in the field.
Well, thank you for sharing that, Rebecca. That's a fantastic story. Dr. Parker, you're a primary care physician. You're interacting with patients all the time. How do you relate to Rebecca's story? How is it to be in the front lines with patients requiring care and seeking diagnoses?
Well, there are two things that Rebecca said when she talked about best practices. I listened very carefully to what she said. And one of the things she had access to 6 years ago, which isn't really commonplace, wasn't commonplace then and is commonplace now, is she had a PET scan. A PET scan kind of definitively provides a diagnosis of Alzheimer's. And that's why her providers were probably able to do that. They saw the architecture. I don't know what her neuropsych testing was. But for the average patient, we have to go through a lot more. You were probably in a center where people were pretty astute and could provide that. I'm here in Georgia, and if you are within the reach of our university, our primary care sites, and certainly our academic practices, you will get access to some of the things that she mentioned. But to the providers who are not a part of an academic faculty or a university, research university, it is a much longer process. And it begins with the primary care doctor doing some of the screens that she talked about, but also making sure that the symptoms and the things that we are observing are not attributable to something that can be treated, whether that is over medicating, mismanagement of medications, other diagnostic or diseases that may be at play. And so from a medical standpoint, it's my job to make sure that there aren't other things that are causing what we're looking at beyond the memory screen that you do in the doctor's office. If I've had surgery or something like that, I may not answer well. So a screening exam is just a screening exam. Then you have to go further. You have to have radiologic tests. You have to have neurocognitive testing, which is generally done by a PhD clinical neuropsychologist, not an MD. So beyond the medical evaluation, it's having access to the other providers who help make that diagnosis, the neurocognitive testing, having a radiology point of access that can do a PET scan, which is state of the art. But that's not always available, and that has not been available to this point for all medical providers. And then you also have to have medical providers who are aware of what the next steps are if we've evaluated all medical things. What is the next step in a dementia evaluation? And unfortunately, all medical providers, whether they're primary care providers or even general neurologists practicing outside of academia, aren't on the same page.
Thanks for that. Very, very insightful. And Jeff, let's turn to you, Dr. Burns. You're a specialist now, so you're receiving referrals from primary care physicians. What's your experience? What's best practices there?
Well, there's a lot of gaps, as Rebecca pointed out, and we've been working hard for 20 years to try to fill those gaps. So yeah, I'm a specialist, and there's 3 other cognitive neurology specialists that are part of our memory clinic. We also have a lot of responsibilities with research, but 4 specialists who are doing clinic sort of part-time is not enough for Kansas City, and it's not enough for the state of Kansas, not even close. And so, we are working hard to expand our memory clinic, but it's not that alone isn't the answer. And so we've worked hard in a lot of different ways to try to fill those gaps. We have education programs, for the community looking for more information. We do a newsletter, a weekly webinar, caregiver support groups, but also caregiver support online. And so we're really trying to listen to what are people asking for, and what can we create and invent and try to provide the community to maximize that impact. So I think education programs is a big part of what we do. But the other thing we do is we really try to fill that gap between visits. You can't just go see the doc every 6 months and that's it. That's just not enough. And so that's a hard gap to fill, but we've created a program that we call our Cognitive Care Network, where it's now 9 social workers. And the social workers are helping people, with education and counseling as needed in between visits, calling people routinely about once a month and checking on them and, stepping it up for people who need more support and, can reduce it for others. And so that's a big part of what we do, to try to really fill that gap between visits, and help caregivers and help patients. And no one's ready for this. No one's prepared, especially the caregivers. And so, we're working hard to fill that.
I think Rebecca made that point very well, that she wasn't thinking about Alzheimer's disease when she got lost on the way to her appointment. So, Monica, I want to come back to you and ask a little bit about your relationship with specialists like Jeff, but you're probably not fortunate enough to have quite people like Jeff. Few of us are. So tell us a little bit about how you, as a primary care physician, relate to the specialist community. What are the triggers for a referral, and what are the challenges to referral?
So for me, most of my professional career has been within a primary care practice in a large university-based healthcare network. So I have been able to make referrals to neurologists and other subspecialists as required without much difficulty. However, that becomes more difficult when, as Dr. Burns said, there aren't that many neurocognitive neurologists that are available to send your patients to. So then a lot of the legwork or the workup that takes place before you get to the neurologist has to take place with you where you are. So when it came to cognitive testing for me, outside of the rehabilitation spaces where they had neuropsychologists, we have universities that will also offer and provide neuropsychologic testing. What I was able to do as a primary care doctor was try to get together as much information, whether it had to do with brain architecture, et cetera. And by the time they got an actual appointment with the neurologist, they had a lot more information to work with. And I think that they would say to me, well, why do you send them here? You've got all of this. I said, because you're the neurologist and I need you to make sure that I've done everything I needed to do. And is there anything more? Now, here in the state of Georgia, for example, we have a statewide network of primary care networks, kind of organized the way we do evaluations here, where primary care doctors can refer their patients in for definitive neurologic testing, which has to do, in our case, a lot of times cerebral spinal fluid analysis. Um, we may not have statewide availability of definitive PET scans for looking at the brain, but most hospitals will have MRIs, but they may not have PET scans. And so getting people referred into our main campus for something like that is generally a little bit easier if you have some of that together. But for the average primary care provider, you have to work through the resources and the specialists that are available to you. And they may not always be at an academic health center. They may be local uh, universities. I mentioned that before for neurocognitive testing. When it comes to most Alzheimer's research, getting your patients involved in research, most of the definitive Alzheimer's research is going on in a university setting. But as time has gone on, we're learning how to better engage people across the community, across places, across the state in different aspects of neurologic research. But it's really important to have a network of subspecialty providers that you can refer to. And that's not always in an academic medical center. That may be at a university. It may be at a teaching hospital that is not affiliated with a university. But generally, if you have a memory assessment site in your state, that may be a resource. It's all very
Thank you for that. I think what I'm hearing there is best practices about a physician network that allows these kind of referrals. Jeff, I'd like to turn to you about the other end of that. You're the specialist in a network. Can you tell us about how you interact with primary care docs from your perspective?
Yeah. So, I mean, we're working really hard to try to think about how do we, develop new models of care that bring together primary care and specialists in more efficient ways. And so we have a health system wide project that we're working on, but we also have this cognitive care network, which I mentioned earlier, where that's 120 primary care docs that we're supporting. And our social workers are going to their offices to support the care that they are providing their patients in their community. And so that's important. But, I don't think the answer is to work, it isn't going to be telling the primary care docs, send people to our memory clinic and they get in the back of the line and wait 6 to 12 months to get in the door. That's the way it is now. And as demand continues to go up, those lines are just going to get longer if we think that's the solution. And so we've got to do something new, and we have to think about how do we, create new architecture within our memory clinic. So, for instance, we have 2 subclinics now. One is called our anti-amyloid treatment clinic, which is the new drugs. And it's a quicker way in for the one purpose of, is this patient eligible and is the drug right for them? And then prescribe it, monitor. And then we're creating a support clinic where if a patient does have a firm diagnosis made by their primary care doc or maybe a neurologist, but they need more support, we're creating an avenue in for that kind of support. And we're building those subclinics on advanced practice providers, so nurse practitioners and physician assistants. And where there's a bigger supply of those experts who we train as well. So, but these are sort of tools for primary care docs, to support the care that they are providing. And another way to think about it, it's co-management of their patients for these things that are really hard to access. And so, a couple examples of, we're really trying to innovate within our clinic to provide, these avenues to support the care that primary care docs can provide their patients.
And do you find, Jeff, that the primary care docs are identifying patients in the way we would like early on, first symptoms? Is that happening or not?
There's work to do there, a lot. So some, but probably not the majority. And they are asking for help. They're asking, they recognize that, this isn't going to be solved by specialists alone. And there's other diseases where primary care, like diabetes, primary care has worked with specialists to develop ways to scale up to better, meet the need. And so our primary care docs are telling us, we want more, we want to understand better how to screen, create tools for us, that we can put in the electronic medical record to screen patients, and blood biomarkers are coming. Help us understand what those are and how we can use those. So they're asking for help, and knowing that they are a key part of, the solution.
Great, thanks. We'll come back to the blood biomarker question in a moment, but Rebecca, I'd like you to reflect a little on the discussions that you've heard here. Does this resonate with you in terms of the relationship between the primary care doc and the specialist doc? How can we operationalize that into best practices?
Well, it does resonate, but I would simply make a plea that we need more doctors. We just need more neurologists and more primary care physicians. When I started out 6 years ago, I saw my neurologist once every 3 months. Then it went to once every 6 months. Now I'm really lucky if I see her once a year. I'm in a part of a nonprofit health system, and they are just stressed to the limits. And I live in a fairly urban area. As Dr. Parker says, you get out in rural areas and it's even worse. I have a friend who lives in Wyoming. She's in the mild cognitive impairment, the very early stages of Alzheimer's. She has to travel about 200 miles to see a neurologist. So we need more doctors. So if you have grandchildren or children, get them to medical school ASAP. Secondly, we need as the doctors have said, more training, both for primary care and also for nurses, PAs, and others. There's so much they can do. Once you get your diagnosis, there's no reason that a nurse or a nurse practitioner or something couldn't provide some interim support. So I think we just need more education. We need more doctors, and we also need, and I guess since I'm the patient, I can say this, a insurance or healthcare system that supports all of us. Because if you have to go out of network, like I occasionally have to do just to get care, it is so extremely expensive.
Thank you for that. Jeff, I want to come back to you about increasing the workforce. You mentioned that you work with advanced practice providers, for example. Could you tell us a little bit about that? And then, Monica, I'll come to you and ask you about your experience with non-physician workforce members. So, Jeff, what are you doing?
Yeah, well, Rebecca said it right. We need more neurologists. We need more doctors. We also need more, advanced practice providers who have training in this area, because the workforce issue is a huge one, and it's holding us all back. There just aren't enough doctors. There aren't enough trained advanced practice providers, and so we do have a physician fellowship where we train docs to be dementia specialists. We also created, about a year and a half ago, we created what we think is probably the first dementia-specific training fellowship for advanced practice providers, and that includes a rural advanced practice provider aspect. So, and it's a 6-month paid program where we pay them to basically train with us for 6 months, and that's what we do for the physicians too. Right? They're paid for 2 years, but that we've got to do more to develop the expertise to help diagnose. In the case of APPs, they can diagnose many patients, but not all. We still need the cognitive neurology expertise, but they can truly support and help care for and manage patients for the long term. And I think they do a better job than I do in the clinic for those types of patients. And so, we really have to grow the workforce, and we have to have new training programs to build that workforce.
And Jeff, are your advanced practice providers, can they do the work of the monoclonal antibodies and following the infusions, following the MRIs? Is that a role they can take on?
Yes, very much so. I oversee our treatment clinic, but the nurse practitioner is seeing the patients, is walking through, the risks and, the pros and cons of treatment with the patients. And I support that final decision of treatment. But then the nurse practitioner does do the monitoring for side effects and works with me if we have to make adjustments. But the majority of the work is being done by nurse practitioner.
And Monica, what about in your system? Are you using nurse practitioners more to try to reach more patients? What's your experience there?
Well, there's several different models of care here. I would start by saying that in the cognitive neurology clinic here, the advanced practice provider RNs are people who are following the patients once the diagnosis has been made. And most of the time, when the diagnosis has been made, most patients are sent back to their primary care doctors for chronic disease management. And for people with advanced dementia who are not candidates for things like the monoclonal antibodies, they have to receive continued medical care and management. And that may be done by their primary care doctor. It may be done in the neurology clinic. The advanced practice providers do the neurologic things, but chronic disease management, most patients with dementia have other chronic illnesses that need to be managed. That's done by their primary care doctor. Here we do have a system called the Integrated Memory Care Clinic, which is kind of like what Dr. Burns described. Patients with dementia, advanced dementia, receive most of their primary care and neurologic and psychiatric management, medication adjustment via advanced practice provider. If you don't have that kind of setup with a collaborative relationship with a neurologist, I think that the model for most patients, for my patients that are not within the Emory healthcare system, they just come back to our clinic and they have to see the nurse practitioners and the providers that we have. So I think that the model going forward looks like once a diagnosis has been made, your day-to-day care is going to be in the care of a primary care advanced practice provider or a primary care physician, wherever it is you happen to be. But diagnostically here, the neurologist makes the diagnosis. And for the monoclonal antibodies, that is administered by a neurologist in our setting. That is not administered by an advanced practice nurse.
Mm-hmm. Okay. And is the system working such that there is not a long waiting list? Are people able to get in to see someone in a relatively short period of time, or are you just overwhelmed in the system?
I think it depends. If the patient that's referred in has all of the things, you have imaging, you've had documentation of all medical problems being stabilized, it's really not that much. There isn't a whole lot more diagnostic work that needs to be done. I think that's being done fairly efficiently.
Very good. And Rebecca, what about your experience with advanced practice providers and nurse practitioners and that sort of thing? Are you comfortable having your care delivered by someone who's not a neurologist or not an MD, but who is knowledgeable about these disorders? What's your thought?
Yes, I absolutely am. I mean, I think Dr. Burns said they could sometimes be better with patients than the doctors. And I have fabulous doctors as we have with us today. But my experience with nurse practitioners and other advanced medically trained people is fabulous. I think, I'm happy that I am under the care of a neurologist and a primary care physician, but on a day-to-day basis, I am thrilled to see a good nurse practitioner, for instance.
And you mentioned that it's a year between visits with your neurologist.
Correct.
Do you see a nurse practitioner between those visits?
I have access to a nurse practitioner through my primary care physician who has some advanced training in memory care, but my neurologist does not have one. And I don't live too far from Kansas, so I'm sitting here dreaming, could I Could I sneak over to Dr. Burns's clinic if I need to?
Anytime.
Okay.
That's great. Well, I think one of the things I'm hearing here is that best practices may involve workforce development so that we're able to absorb a larger workload that we can foresee is coming, and which we welcome because we want earlier diagnosis, more diagnosis, and better care. Jeff, I want to come back to one thing that you touched on, which is the coming blood-based biomarkers. We know that we're very close to a biomarker that can be diagnostic of Alzheimer's disease. This is the p-tau217 test that looks so promising at this point. It's essentially as good as spinal fluid in terms of the numbers that we have available to us. So let's start with you then, Jeff. Is this a game changer? Is this going to radically revolutionize what you do in terms of care?
Well, I'd say yes, but not overnight. I think this is a new tool that has really amazing potential, to really change how we diagnose, and not just in the memory clinic, but in primary care. But it's not going to happen overnight. There's a lot of barriers to using it well, and one of the big ones is we got to use it in the right context. And so primary care docs, for instance, have to have the other things, that Monica's been talking about, that, imaging and cognitive testing and and the history, know how to take a good history about, the cognitive changes. And so we have to create those tools to accompany the blood tests. We can't just flip a switch and turn on blood tests, make them available to everybody and expect it to be a game changer. But I think it will be a game changer once we figure out how to implement right and do the education that's needed and give the primary care docs the tools they need to interpret those tests right and use them to make an accurate diagnosis.
Sure, I'll come back to that. But Monica, I know you have a comment you'd like to make, so please.
Well, I actually have a question for Jeff. We're talking about nurse practitioners. We're talking about primary care providers. In the setting of newer treatments, these monoclonal antibodies, we depend a lot on radiologic imaging to follow the course of treatment. And that would mean to some degree that we have to do some, I won't say retraining, additional training for neurologists. I don't think, radiologists, excuse me. All radiologists are not the same. I know that in my center, because we talk about it a lot. What about training for radiologists to monitor these side effects? I mean, advanced practice providers are nice to go along, but if we're on these treatments and we're 200 miles away from where our providers are, the radiologists and the primary care doctors have to be able to recognize what those problems are. So in Kansas, how are you training radiologists?
Yeah, that's a great question. And that's a huge, important issue as, when we're monitoring these MRIs, then we have to have radiologists that are trained and tuned in to detecting that. And we had some growing pains here, within our health system, academic health system, where, so it's not simple. And I think that challenge is magnified if we're doing MRIs, 300 miles out in Western Kansas, for the first time looking for ARIA. So we're demanding that people come to us to get their MRIs done, but we're beginning to work with imaging centers and talking to radiologists and making sure that they're tuned in and trained up and, have the right sequences for the MRI to detect these side effects that we worry about.
I think another exciting development is artificial intelligence applied to MRIs. The data look pretty good at this point in terms of AI applications being as good as, if not maybe better than, many radiologists in terms just of the sensitivity to change, which is very hard to see with the naked eye in some cases. Monica, I want to be back to you about the blood test and think a little bit about the impact of the availability of a blood test for Alzheimer's disease on your practice? What would that look like?
I think that if insurance covered it and it was an affordable option, that certainly for me, and again, I've had the benefit of working alongside neurologists who are working in research and seeing my patients. I would be very comfortable utilizing biomarkers because I would feel comfortable with the next step. I'm not sure that people who are family physicians in other parts of this state would be as comfortable. Um, for example, if it would be good to help with the diagnostic process, and I'd be happy to use it within proper guidelines. But I'm aware of that because I've had the benefit of working alongside the neurologists as these developments have been made. So I'm aware of the challenges, but everybody who's like me in this state hasn't had that advantage. But I think it would be helpful if we have done the diagnostic workup and maybe we don't have somebody available who can do a lumbar puncture because that's part of our diagnostic workup. I think being able to say, we've got these MRIs, this is what we found, and we've done the blood biomarker, and this is what we found. I think that would make it a lot easier for providers. I think it would be a lot more cost effective for those of us who see not only patients who are, how do I say this, underinsured or non-insured, in communities where they're non-native English speakers. That's always been a barrier. And clinically now, a lot of the patients that I see are non-English speaking. So I'm in for Medicare, Medicaid, and universal coverage for PET scans and for blood biomarkers that can give me the result I need independent of whether or not I speak English or Spanish or Chinese or anything else.
That's a really good point. Jeff, I want to, Rebecca, I'm going to come to you, but Jeff, I want to come back to you and ask about how you see the implementation of the blood test. Is this, let's say it's positive. Is that a shortcut to the APP to decide whether they're a candidate for therapy? Or how much would you expect the primary care practitioner to do in addition to a blood test? How do you see it?
Well, yeah, so I think we can do a lot of this in primary care if we have the cognitive screening and the biomarker support. I think in primary care we can get an accurate diagnosis, and that's hard to implement. But then from there we can get primary care docs referring into our memory clinic if it's in our world, a straightforward diagnosis, and there's not a lot of sort of cognitive neurology complexity to it. It looks like Alzheimer's from every angle. Nurse practitioner can help provide the support and the sort of long-term care for a good percentage of our patients. So without requiring that need to get in the back of the line to see a cognitive neurologist. And so, that's one example. The other example would be, yes, if the diagnosis is clear and they're in the early stage and it looks to be, amyloid is present in the brain and they look to be a candidate for the drug, we can fast track them in to our treatment clinic, led by advanced practice providers, but also overseen by neurologists. So they're not alone. But I think this idea of if we can get this diagnosis, more rapidly and accurately done in primary care, we can create these new pathways for these, purposeful support systems within specialty care. So treatment clinic is one example, and the support clinic for the, the counseling, the education, the discussions about driving and things like that can take up so much time for the family and the physician. So those are the ideas that we are working on to try to create those new sort of models, those new avenues for care.
So I like that as a best practice idea that a person who has a positive blood test could then be referred through special pathways that one might consider a treatment with a monoclonal. Now, what about the person with the negative blood test? And they're symptomatic, they have cognitive abnormalities, and now we know that they wouldn't have an Alzheimer confirmation. What happens to that patient in the system you envision?
Well, that patient, yeah, that's one where the primary care, we would coach the primary care to think harder about things like sleep apnea and depression and, you know, laboratory thyroid, low thyroid, so other potential causes. And then if it's looking to be some other form of dementia, we could get them into our complex diagnostic clinic, or in the support clinic if it does look to be something like this newer uh, uh, um, disease late, which is pretty common. So yeah, we can get them into our support clinic for the long term.
Great, thank you for that, Rebecca. Let's come to your experience. How would your engagement with the healthcare system have changed if you had had a blood test early on that said you have Alzheimer's disease?
Well, I think the underlying message here has to be the earlier the diagnosis, the better. And if the blood test could have helped me even earlier, that would have been incredible. I changed my lifestyle, I reduced my stress. That's the key. So the earlier the better. The second thing I want to underscore is what Dr. Parker said. This potentially, if insurance covers it, or yes, universal coverage, will mean that we expand access. On the one hand, we're discussing mainly the scientific side. But let me just say for a moment, equally problematic is that people don't go and report to their primary care physician. They're not asking questions. This is a scary disease. I think the research side, I think biomarkers, when it's all developed and insurance is covering it, will reduce the stigma about getting tested. Right now, we're undergoing massive education of the public to try to get them to go to their primary care physician. If they can think that they can go to a Dr. Parker, they can just get a blood test, and that could start this process. That could be revolutionary.
Revolutionary. Okay, great. And Jeff has pointed out that this is a slow revolution that he expects, not a fast resolution. I think that's an appropriate caution that it takes a lot of education to learn how to use blood tests well. And I think we're in that transitional phase right now, trying to understand what is their role in terms of diagnosis and management. I'd like to take up another kind of question now. Rebecca, I'm going to start with you for this. I know you've been a member of Voices of Alzheimer's Disease. Tell us a little bit about your participation in that group, and more broadly, are there support groups that have been useful to you in your journey? Let's step outside of the direct medical care discussion for a moment and think more broadly about what patients need once they have a diagnosis.
I think anytime you have a major disease or a major life-changing experience, talking with other people who have going through the same thing is so beneficial. So Voices of Alzheimer's it was started by Jim and Jerry Taylor, who got together a group of people who, like Jerry Taylor, had Alzheimer's. So we really started as a support group. Then we became more of an advocacy group. And I have participated in any number of support groups. I'm a frequent speaker, and I also am a frequent attender, because not only support, I think education is power. And the more you can get educated and your care partners can get educated about this disease, the better you are, I think. I didn't know much. I mean, I remembered my mother and my grandmothers. They were terrible memories. They were all diagnosed very late in the disease. But as I got educated, I realized there is so much you can do. So I became an advocate. I'm co-founding members of Voices of Alzheimer's. I'm on the board of Us Against Alzheimer's. I've been on the board of the National Alzheimer's Association. I ask everyone, care partner, patient, general public, to get involved and to get knowledgeable. I think that's good for all of us because many of us, as we age, will get this disease or will be taking care of someone with this disease. And if you aren't doing it directly, your neighbor, your best friend, your cousin will be one with this disease.
Thank you. Very good. Monica, let's turn to you. What's your experience with support groups, Alzheimer's Association, Voices of Alzheimer's? But how has that worked for you? Is this something you offer your patients?
Yes, I think that advocacy organizations, I'm going to use that word, whether it's the Alzheimer's Association, Voices of Alzheimer's is one, Alzheimer's Foundation of America. These different organizations have support groups. They offer different kinds of support in the community. One of the groups that I'm a part of, Alzheimer's Foundation of America, does a lot of workforce training and development, as does Us Against Alzheimer's. They have a nurse fellowship for nurses to increase their awareness and knowledge about Alzheimer's and what's available to help treat them. As a clinician, because I have to see patients, I can't hold your hand and I can't give you all of that education. I refer to advocacy organizations. And a lot of these advocacy organizations will provide the word is case management. Like some medical practices will have a social worker. In our practice, we did not have a social worker. And a lot of primary care practices don't, but a lot of these advocacy organizations do have social workers that they pay that will help families with case management and the sorts of social work kinds of things that I can't do. So I generally hand off to one of those organizations. And there are local organizations that offer a lot of support. In Metro Atlanta, one of the best ones is offered by the Jewish Family and Community Services. They provide training, they provide respite care, they provide vouchers so that families can get in-home care and help families identify where they can get in-home care. And in-home care, as many of us on this call are aware, is usually an out-of-pocket expense. And for aging families and families who may not have the income to independently hire them, a lot of these advocacy organizations can provide a resource and help those families get that kind of service.
Great. Thank you for that. And Jeff, I'm going to come to you with this question, but I want to alert our panel to the fact that we're coming to the end of our time. And I am going to ask each of you to just articulate one or two best practices that you would like to see implemented in primary care, specialty care, other aspects of care for Alzheimer's disease. But Jeff, let's hear about your experience with support groups, Alzheimer's Association, Us Against Alzheimer's, Voices. What organizations have you found useful, and how do you use it with your patients?
Yeah, well, they're all important. And I mean, this is a community effort. It has to be a community effort. It can't just be a center or a researcher or a clinic. It has to be a community effort. And so we partner with all those organizations, but we, locally, we work with, I wouldn't say, actually, in the middle of Kansas, we work with a group called OCCK for better, we're working for better access to rural communities. In Kansas City, we're working with El Centro and the Black Healthcare Coalition. We've been working with them for a long time to really try to improve access in urban and underrepresented groups. But I do want to point out, the other important thing is a lot of this stuff, pretty much everything I brought up in terms of our care network and our educational programs, our social work support group, we got 9 social workers. These don't provide a return on our investment. And so we committed to growing these things and without a clear return on investment. And at this point, and so how do we do it? Well, philanthropy has played a huge role. So people in the community who are supporting us building these programs. And we're also partnering with some groups. The NIH has supported some. The Davos Alzheimer's Collaborative is supporting our efforts to really build this health system-wide dementia care program. So, it takes everyone and community groups and centers like ours coming together to fight this battle.
Thank you. Yes, and I think the philanthropy is so important. Now we're down to just a few minutes left, so I want to ask each of you to just very briefly say one or two things about best practices that you would like to leave our audience with. Rebecca, let's start with you.
One best practice would be to expand the workforce and to educate more nurse practitioners, etc. The second best practice I want to underscore is that there are lifestyle changes that we can all adopt right now to have a brain healthy lifestyle. So if you get Alzheimer's, diet, exercise, creativity, sleep, reduce stress. But if you don't have Alzheimer's or don't have it yet, do those things. Have a brain healthy lifestyle.
Thank you. Monica, how about it? One or two best practices here?
Take advantage of your annual wellness visit. And during that time, that's a time in which your primary care doctor can give you a memory screen, an anxiety screen, and depression screen, and start the kinds of evaluations that we've talked about here. Annual wellness visit. Everybody needs one.
Great. Love it. Thank you for that. Jeff, how about one or two best practices?
Okay. Well, so, we need to get better at detecting, early and diagnosing accurately in primary care. Then we need to get better after a diagnosis is made at providing the support and the care management, and the lifestyle, the lifestyle adaptations and coaching and providing those things. So glad Rebecca brought that up. So that care management after a diagnosis is made. It can't just be see the doc once a year, every 6 months. It has to be. We have to have sort of multidisciplinary support from social workers and other lifestyle, hopefully, coaches. So we need to get better at that.
Great. And I would just add the network of primary care and specialists and other workforce members, really important. And the coming blood tests are likely to be extremely useful. So we're all looking forward to that. I want to thank our panelists. What a great panel. My gosh, I've learned so much in the last hour. So thank you all for being here today, for contributing in this important way. And I'm sure our audience really went away very enriched in terms of their understanding. Thank you so much.
Dr. Cummings, thank you and the entire panel for this important conversation. Coming up at 2:30 Eastern, we'll talk about the important insights clinicians have gained when it comes to treating people with innovative medications now on the market. Stay with us.